Well, we've assembled a team of medical oncologists who are all board certified by the American Board of Internal Medicine. So first and foremost, no matter where our doctors are coming from, whether they're men or women, Asian, Caucasian, Indian, whatever race, color, or creed, there's one unifying fact, and that is we all have American Board certifications in medical oncology. We've set up a high-end video conferencing unit that could be described as telemedicine. It allows us to have both doctor-to-doctor communication, nurse-to-nurse communication, and most importantly, doctor-to-patient communication across Southeast Asia. So we have our main telemedicine hub here in Singapore, but we've now put in centers in Shanghai. We have a center in our U.S. office, and we'll be placing another center in Jakarta. We'll be placing a center in Bangladesh, and we'll be placing a telemedicine center in Vietnam. So we think that by being able to communicate with our patients more regularly, that we will be able to enhance the quality of care for West Clinic patients and families. I would emphasize that I don't think that telemedicine is the best way for initial consultations. I don't think anything is better than a face-to-face examination and interview when you're meeting a patient and a family for the first time. But after we've had that face-to-face interview and we're all on the same page with treatment goals and expectations, I think that the telemedicine approach is a great way to keep in contact. It's not a great way to get to know someone, but it's a fabulous way to keep someone under your watchful eye and under the control of our West Clinic nurses and doctors around the world. I think that that's where it's best used in long-term follow-up because, for example, if my patient is treated every 3 weeks with chemotherapy and goes into a remission, do I really need to make that patient fly to Singapore every 4 weeks for me to examine them and find out how well they're doing? Or can I go every other visit and just make sure that I do a 15-minute interview via telemedicine and make sure that there's nothing being overlooked, that we can review the laboratory tests, and we can reassure ourselves that the patient is doing well and can follow up with me in another 1 or 2 months down the road for a physical examination as well as interview.
Okay, so a PET scan, that's a good question. It's a relatively new technology, and it's technology that has helped us oncologists to treat a patient better. Way back in the 1930s, someone had this remarkable look into tumors and figured out that tumors basically ate what we ate. And they took in sugar compounds like we do. And somebody then put on that idea to put a radio tracer onto the sugar molecule. Wherever the sugar molecule goes to, on a PET scan, that area would light up as a very darkened area. So, in a normal person, your brain and your heart would certainly be very dark in color in a PET scan because it's constantly taking up sugar all the time. So, even if I try to sedate you with some medication, they will still appear black in color. So for the tumor, if it was alive and active, then it would take up the sugar compound and show up the spots, various parts of your body if it's spread anywhere else, and give us an idea whether the tumor is more localized or elsewhere. Now this has an additional advantage over CT scans because CT scans is a very static picture. It's not a dynamic picture at all. So the PET scan gives us a functional idea of how the tumor is behaving. Now in isolation, the PET scan may be very hard to interpret. So typically we would do a CT scan at the same time in order to localize with precision where those areas of activity are. That being said, we still use a lot of PET scan nowadays for the treatment of our patients. And even before that, the staging of our patients. As I said earlier on, it'll give me an idea in the terms of the cancer, whether it's localized or spread to other parts of the body. And in terms of treatment, it's very useful because I can do the PET scan before treatment and after treatment and compare whether the patients responded to my treatment. It has even gone further ahead And some people are using midway during treatment to give us an idea whether the patient will do well or poorly following the treatment for their cancer.
Now, after that, we have created a group of doctors that have different expertise. While we all treat all cancers and we all have been trained to be generalist oncologists, we each have our own unique specialty. My interest and expertise, for example, is in breast cancer and prostate cancer. Dr. Mao, our newest addition, is an expert in lymphomas, leukemias, myeloma, and bone marrow and stem cell transplants. Our third doctor is an expert in tumors of the head and neck and brain. We have a fourth doctor joining us who's an expert in lung cancer and women's health cancers like ovarian and cervical cancer. And we'll have a fifth doctor joining us at the beginning of 2008 whose expertise is gastrointestinal cancers like colon cancer and liver cancer. Now, we all do see the patients who come in the door, but I think it's very important that patients have choices, that I can tell a patient, listen, I've been seeing lung cancer for the last 15 years, and I'm happy to take care of you. And it's good news that I've asked my colleague, who's a lung cancer expert, about your case. Or I can tell the patient, you know what? This is a complicated case of lung cancer that's not so straightforward. I think it would be better if you spent some time with my colleague who's an expert in lung cancer. So this way, patients and their families get the best of an individual physician and the collective group of experts that go to make up the West Clinic.